For 3 years, head nurse Rebecca Martinez had endured the whispers, the complaints, the constant criticism from colleagues who called her too slow and overly cautious. She never defended herself, never explained why she approached every patient like their life hung in the balance. Some secrets, she knew, were worth more than her reputation. Welcome to the hidden stories. From which city in the world are you watching this video today? If this story intrigues you, please consider subscribing to hear more untold stories of extraordinary service and the heroes who walk among us, never asking for recognition they deserve. The morning shift at St. Catherine's Medical Center begins. Like any other, with the familiar sounds of monitors beeping, phones ringing, and the steady rhythm of a busy urban hospital. In the cardiac intensive care unit on the 3rd floor, head nurse Rebecca Martinez arrives 30 minutes early, as she has every day for the past 3 years. At 34, she moves with a deliberate precision that some colleagues mistake for slowness, checking and double-checking everything from medication dosages to equipment settings. Dr. Patricia Hawkins, the department chief, watches from her office as Rebecca methodically reviews each patient file before rounds. There she goes again, Hawkins mutters to herself, noting how Rebecca takes twice as long as other nurses to complete the same tasks. What Dr. Hawkins doesn't see is the way Rebecca's eyes scan each chart, looking for subtle patterns that most medical professionals would miss: signs of internal bleeding, early sepsis indicators, medication interactions that could prove fatal. Rebecca approaches room 312, where elderly patient Robert Chun lies recovering from cardiac bypass surgery. The standard protocol calls for routine vital checks every 4 hours. But something in Chun's breathing pattern triggers an alarm in Rebecca's mind. She's seen this exact presentation before, in a very different setting, under very different circumstances. "Mr. Chun," she says softly, "I need to listen to your chest again." Chun, a retired postal worker, manages a weak smile. "You checked me an hour ago, dear. I'm fine." But Rebecca's trained ear detects a subtle change in his lung. Sounds a slight wheezing that others might dismiss as normal post-surgical congestion. In a field hospital in Kandahar province, this same sound preceded a fatal pulmonary embolism in Sergeant Michael Torres. Rebecca had caught it then, saved Torres's life with immediate intervention. She won't miss it now. "I'm going to order another chest X-ray," Rebecca tells Chun, already reaching for the phone. Dr. Jennifer Walsh, the attending physician, arrives 20 minutes later, clearly irritated. "Rebecca, his morning X-ray was completely normal. We can't order imaging every time you have a feeling about something." Rebecca's jaw tightens slightly, the only outward sign of her frustration. "Doctor, with respect, I'm seeing early signs of possible complications. His oxygen saturation has dropped 2 points in the last hour, and his breathing pattern suggests..." "Suggests what?" Dr. Walsh interrupts. "Rebecca, you're a nurse, not a radiologist. Mr. Chun is stable. His vitals are within normal range. And frankly, your tendency to over-medicalize every situation is becoming a problem." Other staff members in the hallway pause their conversations, some nodding in agreement with Dr. Walsh. Rebecca has gained a reputation over the past 3 years for being too careful, for questioning orders that other nurses would follow without hesitation, for insisting on additional tests that administrators see as unnecessary expenses. Rebecca doesn't argue further. Instead, she returns to Chun's bedside and quietly increases the frequency of her checks, monitoring him every 30 minutes instead of every 4 hours. She documents everything meticulously: respiratory rate, oxygen levels, skin color, mental alertness. In Afghanistan, this level of vigilance had meant the difference between life and death for hundreds of wounded soldiers. 3 hours later, Robert Chun goes into respiratory distress. His oxygen saturation plummets. His breathing becomes labored. And Rebecca is at his bedside before the monitors even alarm. Her hands move with practiced efficiency, elevating his legs, administering oxygen, calling for emergency intervention. "We need a pulmonary angiogram now," Rebecca tells the crash. Team as they arrive. Massive pay, bilateral involvement likely. Dr. Walsh stares at her in confusion. How could you possibly know that? Rebecca doesn't answer, too focused on stabilizing Chun's breathing. The subsequent imaging confirms her diagnosis multiple. Pulmonary emboli that would have been fatal if not caught early. Chun survives because Rebecca refused to follow standard protocol, because she trusted her instincts over institutional guidelines. But instead of recognition, Rebecca faces another meeting with Hospital Administration. Chief Administrator Margaret. Thornton sits behind her desk the following morning, reviewing Rebecca's personnel file with obvious disapproval. "Ms. Martinez, this is the 4th incident this year where you've contradicted a physician's medical judgment. Yesterday's situation with Mr. Chun could have been handled through proper channels." Rebecca remains silent, hands folded in her lap, maintaining the respectful demeanor that had served her well in the military chain of command. "You saved his life," continues Thornton, "but you also undermined Dr. Walsh's authority and ordered expensive tests without proper authorization. Your colleagues are concerned about your unconventional approach to patient care." Unconventional. Rebecca almost smiles at the irony. In the 67th Combat Support Hospital in Afghanistan, her unconventional approaches had earned her a Bronze Star, a Purple Heart, and the respect of every surgeon who had worked with her during the deadliest year of the war. But those decorations sit in a box in her apartment, never displayed, never mentioned. "I understand, Mrs. Thornton," Rebecca says quietly. "I'll be more mindful of following established protocols." But even as she says the words, Rebecca knows she can't change who she is. 3 years of civilian nursing haven't erased the instincts developed during 18 months of combat medicine. When she looks at patients, she doesn't see routine cases. She sees Private Jackson with the same abdominal pain that preceded a burst appendix, or Lieutenant Hayes with the same cardiac rhythm that had warned of an impending heart attack. Pattern continues over the following weeks. Rebecca catches an early-stage stroke in a patient dismissed by others as confused. She identifies a drug interaction that prevents a near-fatal allergic reaction. She spots signs of internal bleeding in a post-surgical patient 12 hours before lab results confirm her suspicions. Each time she's proven right. Each time she faces criticism for not following standard procedures. Her colleagues begin to whisper more openly. "Martinez thinks she knows better than the doctors," they say. "She's too intense, too paranoid about everything." Some speculate about her background. She never talks about her previous experience, never socializes with staff, maintains a professional distance that others interpret as arrogance. Nurse manager Linda Stevens approaches Rebecca during a quiet moment in the break room. Stevens, a 25-year veteran of St. Catherine's, has watched Rebecca's struggles with growing concern. "Rebecca," Stevens says carefully, "I need to ask you something, and I hope you'll give me an honest answer. Where did you learn to practice medicine?" "Like this?" Rebecca looks up from her coffee, meeting Stevens's eyes for a moment before looking away. "I don't practice medicine. I'm a nurse." "That's not what I mean, and you know it," Stevens presses. "The way you assess patients, the patterns you see, the interventions you suggest, it's not what they teach in nursing school. You've got combat experience, don't you?" For a moment, Rebecca's carefully maintained composure slips. Stevens sees something flicker in her eyes, pain, maybe, or loss. But Rebecca quickly rebuilds her walls. "My background isn't relevant to my current position," Rebecca says formally. "I focus on providing the best possible care for my patients within the scope of my nursing license." Stevens nods, understanding that she won't get more information. But she's seen enough to know that Rebecca Martinez carries knowledge earned in places most people pray they'll never see. The breaking point comes on a busy Friday night in October. The emergency department sends up Maria Gonzalez, a 28-year-old woman complaining of severe abdominal pain. The preliminary diagnosis is kidney stones, and the treatment plan calls for pain management and observation. Rebecca reviews Gonzalez's chart and immediately feels the familiar tightness in her chest. That has served as her early warning system since Afghanistan. The patient's pain pattern, vital signs, and blood work remind her sharply of Corporal Amanda Foster, a 26-year-old soldier who had presented with similar symptoms. Rebecca had ordered immediate surgery over the objections of an overconfident physician. Foster's ruptured ectopic pregnancy was caught just in time. "Dr. Walsh," Rebecca says, approaching the attending, "I think we need to consider ectopic pregnancy for Mrs. Gonzalez." Dr. Walsh doesn't look up from her computer. "Rebecca, the patient's pregnancy test was negative. Her symptoms are classic for kidney stones, and the CT scan shows no abnormalities. Please administer the prescribed pain medication and monitor her condition." Rebecca hesitates, remembering Foster's case, remembering the surgeon's words afterward. 5 more minutes, and she would have bled out. But she also remembers the warnings from administration, the whispered complaints from colleagues, the growing pressure to conform to standard protocols. She administers the pain medication as ordered, but increases her monitoring to every 15 minutes. Maria's pain seems to ease slightly, but Rebecca notices subtle changes: a slight drop in blood pressure, a barely perceptible pallor, a restlessness that suggests internal distress. 2 hours later, Maria Gonzalez collapses in the bathroom. Her blood pressure crashes, and she goes into shock from internal bleeding. The emergency surgery reveals a ruptured ectopic pregnancy that had been missed by initial testing, a rare but not unheard of false negative. This time, Rebecca doesn't stay silent during the crisis debrief. "I told Dr. Walsh we should consider ectopic pregnancy," she says firmly, addressing the room full of medical staff. The patient presented with classic warning signs that were dismissed because they didn't fit the standard diagnostic criteria. Dr. Walsh's face flushes red. "Rebecca, you are completely out of line. The pregnancy test was negative. The imaging was normal. No reasonable medical professional would have suspected ectopic pregnancy based on the available evidence." "I would have," Rebecca says quietly. "And I did." The room falls silent. Several staff members exchange glances, uncomfortable with the tension, but unsure whose side to take. Rebecca's track record of catching problems others miss is becoming harder to ignore, but her challenges to medical authority are making everyone uncomfortable. Chief Administrator Thornton calls Rebecca into her office the following Monday morning. This time, she's not alone. Dr. Hawkins and the hospital's legal counsel are also present. "Ms. Martinez," Thornton begins, "we need to discuss your future at St. Catherine's. Your recent behavior has created a hostile work environment, and your consistent questioning of physician judgment has become disruptive to patient care." Rebecca remains silent, though her hands clench slightly in her lap. "However," continues Thornton, "we also recognize that your clinical instincts have been accurate in several recent cases. Before we make any final decisions, we'd like to understand your background better. Where did you develop these diagnostic skills?" For 3 years, Rebecca has deflected this question, changed the subject, maintained the careful separation between her military service and civilian career. But sitting in this sterile conference room, facing termination for the crime of caring too much about her patients, she makes a decision. "I was an Army combatic," Rebecca says quietly. 68W Mos, attached to the 67th Combat Support Hospital. In Kandahar province from 2019 to 2021, the room's atmosphere shifts immediately. Dr. Hawkins leans forward, sudden interest replacing her previous irritation. Combat medic, Hawkins repeats. Not nursing school. I completed my nursing degree after my discharge, Rebecca explains. But my clinical experience comes from 18 months of trauma medicine in a war zone. I treated everything from gunshot wounds to IED injuries to diseases we don't see in civilian practice. Thornton exchanges glances with the legal counsel. Why didn't you mention this in your employment interview? Rebecca's jaw tightens. Because I learned that military medical experience makes civilian hospitals uncomfortable. They want nurses who follow protocols, not combat medics who think every patient might die if they miss something subtle. And why should your military experience matter here? Dr. Hawkins asks, though her tone has shifted from confrontational to curious. For the first time in 3 years, Rebecca allows some of her carefully controlled emotion to show. Because in Afghanistan, following standard protocols got people killed. When you're treating 12 casualties from a roadside bomb, and you don't have lab results or imaging or consultants, you learn to see patterns that others miss. You develop instincts that save lives. She looks directly at each person in the room. Robert Chun, Maria Gonzalez, Thomas Williams, Jennifer Park, 4 patients in the last month who would have died if I had followed standard protocols instead of trusting my clinical judgment. In Afghanistan, I kept 200 soldiers alive by seeing things others missed. I'm trying to do the same thing here. The room falls silent as the administrators process this information. Finally, Thornton speaks. Ms. Martinez, why haven't you shared this with your colleagues? Why maintain such secrecy about your background? Rebecca's answer comes from a place of deep pain. Because I've learned that people don't want to hear about Afghanistan. They don't want to know what it's like to hold pressure on a severed artery while mortar are falling, or to perform emergency surgery in a tent with inadequate equipment. They want their hospital to be clean and safe and predictable. My experience reminds them that medicine can be messy and terrifying and uncertain. She pauses, gathering her thoughts. And because some of the things I've seen, some of the decisions I've had to make, they're not things I can share with people who haven't been there. Dr. Hawkins asks the question that everyone is thinking. What kind of decorations did you receive for your service? Rebecca's military bearing becomes more apparent as she straightens in her chair. Bronze Star with V device for valor, Purple Heart, Combat Medical Badge, Army Commendation Medal with V device. But the decorations aren't why I do this job. The legal counsel whispers something to Thornton, who nods before addressing Rebecca again. Miss Martinez, we need to step back and reconsider this situation. Would you be willing to give us some time to review your personnel file in light of this new information? Rebecca nods, understanding that her career at St. Catherine's hangs in the balance. 3 days later, Rebecca receives an unexpected phone call at home. The caller identifies himself as Colonel James Morrison, Chief of Medical Staff at Walter Reed Medical Center. Ms. Martinez, I hope you don't mind the intrusion, but I received a call from your hospital administrator. She was asking about protocols for integrating combat medical experience into civilian healthcare settings. Rebecca feels a flutter of anxiety. Sir, I hope my military service isn't causing problems for St. Catherine's. Colonel Morrison's laugh is warm. Quite the opposite. I've reviewed your service record, Sergeant Martinez. Your commanding officer in Afghanistan wrote that you were one of the finest combat medics he ever worked with. Your civilian colleagues are lucky to have you. The conversation continues for 20 minutes, with Colonel Morrison explaining new initiatives to help military medical personnel transition to civilian healthcare. By the end of the call, Rebecca feels something she hasn't experienced in 3 years. Validation from someone who understands both worlds. When Rebecca returns to work the following Monday, she notices immediate changes. Dr. Hawkins greets her warmly and asks if they can discuss some of her assessment techniques. Nurse Manager Stevens introduces her to a new resident as one of our most experienced clinicians. Even Dr. Walsh, though still somewhat cool, treats Rebecca's suggestions with new respect. The transformation isn't complete or universal. Some colleagues remain skeptical of Rebecca's methods, but the atmosphere has shifted. Her military background, once hidden, becomes an acknowledged part of her professional identity. 6 months later, Rebecca stands before a packed auditorium at the Regional Nursing Conference, delivering a presentation titled Combat Medicine Lessons for Civilian Healthcare. She talks about pattern recognition, clinical intuition, and the importance of trusting experienced judgment even when it contradicts standard protocols. After her presentation, a young nurse approaches her. "Ms. Martinez, I'm starting work at St. Catherine's next month. I was a Navy corpsman in Iraq. Do you think my military experience will be valued there?" Rebecca smiles, remembering her own fears 3 years ago. "It will be now," she says. "But more importantly, don't ever be afraid to use your training to save lives. That's why we served, and that's why we continue to serve." As Rebecca drives home that evening, she thinks about the 200 soldiers whose lives she saved in Afghanistan and the dozens of civilian patients she's helped since then. The paths are different, the uniforms have changed, but the mission remains the same: to use every skill, every instinct, every hard-won piece of knowledge to preserve life. Some secrets, she now knows, are too valuable to keep hidden. And sometimes, the best way to honor your service is to let others see what it taught you. This story reminds us that heroes walk among us every day, often disguised as ordinary people doing ordinary jobs. The quiet taxi driver, the unassuming mechanic, the reserved librarian, any of them could be carrying incredible stories and extraordinary skills. Have you ever met someone who turned out to be completely different from who you thought they were? Share your story in the comments below. If this story gave you chills or made you think twice about judging people by their appearances, smash that like button and subscribe to The Human Stories for more incredible tales of hidden heroes, secret identities, and ordinary people doing extraordinary things. Turn on notifications so you never miss our latest stories. And remember, never underestimate the person sitting next to you. They might just be the hero the world needs. Thank you for watching, and we'll see you in the next story.